6, sir. We are going live.
Yeah. We can.
Yeah.
No, it is only 5:50, 5:59. Yeah. Dr. Suresh, you can start.
Yeah. Good evening, everybody. This is our online webinar, serial number 24 of Pudukkottai Budan. Today we are going to discuss on airway assessment and airway, difficult airway and anatomical testing. At the outset, I invite our secretary, Dr. M. Periyaswamy, to invite and give the welcome address.
Thank you, sir.
Dr. Periyaswamy.
Thank you, sir. Thank you. Good evening, one and all. On behalf of IACA Pudukkottai, I welcome you all for this 24th online webinar program. I welcome our academic chairman, Dr. A.L. Meenachandram sir, for his continuous active involvement and guiding us to conduct this program successfully on every week. And I thank and invite our President, Dr. Suresh Kumar sir, Treasurer, Dr. David, and members of IACA Pudukkottai, and members, those who are attending this 24th online webinar program from various parts of the country. Once again, welcome you all for this successful 24th online IACA program, Pudukkottai Budan. Already we conducted so many programs in various topics, start from the anesthesia management based on transplant and laryngoscope. Last week, we conducted this program on 3 subjects: anesthesia management of laryngectomy, post-tonsillectomy bleeding, and anesthesia for laser surgery. This week, we are going to talk about airway management. For that, I invite and welcome Dr. Sudhish K, Professor, Bangalore Medical College and Research Institute, Bangalore, to share this session. I welcome you, sir.
Thank you so much, sir. Thank you so much, sir.
And we are having 3 speakers to talk about 3 different topics. I welcome Dr. Caroline Satya Justice, consultant, Apollo First Medical Hospital, Madurai. Madam is going to talk about airway management. I welcome you, madam. Next speaker, I welcome Dr. Shraddha Naik, Professor, Krishna Institute of Medical Science, Karat, Maharashtra. Madam is going to talk about difficult airway algorithm. I welcome you, madam.
Thank you, sir.
Next, resident from Pudukkottai, native of Pudukkottai, doing resident at Maharashtra, Dr. Ratnam PL, resident, Krishna Institute of Medical Science, Karat, Maharashtra. Madam is going to talk about Nasopharyngeal Airway. I welcome you, madam. On behalf of IACA Pudukkottai, once again, I welcome our chairperson and speakers for his 24th online webinar program. And one more thing, our medical online program, this IACA program is accredited by Tamil Nadu Medical Councils, and they are giving credit hours, those who are attending this event on every week. For that, you need certain details, your email ID, mobile number, attendance, and name as registered in medical council. And with this detail, you have to pay 100 rupees for our account, which is mentioned here. If you want, you can note it down, and you have to send it to IACA Pudukkottai at yahoo.com. All details has to send to this mail address to enable us to get credit hours, those who are attending for this event. Today we are going to talk about airway. There is a small poem on that. Airway is either way connects alveoli and atmosphere. Start from the nostrils down to the bronchioles. Conducts the airway, air in the in and out cough out the mucus to protect it, modulating the voice and moisturize the inhaling air. Airway modulating the voice and moisturize the inhaling air, protecting the lungs by pressure reducing cascade mechanism. Airway, maintaining the patent airway is important. Maintaining the patent airway is important to make our life healthier and happy. With this note, I once again welcome you all and thank you for this opportunity given for me to welcome you all. Thank you, sir. Over to President.
Thank you, Dr. Periyasamy. Respected Secretary, Dr. Periyasamy, respected Academic Chairman, Professor Dr. A.L. Meenakshi Sundaram, sir, our Treasurer, Dr. David, office bearers, Executive Council members of ISA Pudukkottai branch, ISA Tamil Nadu branch, and other senior members who are participating here. Our chairperson, respected Professor Dr. Satish K from Bangalore. Speakers, consultant Dr. Carolina Satya Justice Madam, Professor Dr. Sharada Naik Madam, and resident Dr. Ratnam. On behalf of ISA Pudukkottai, I extend my warm welcome to you all and our Ganesh Chaturthi greetings. Today is an important day for us because we are going to deal with airway, which is a very vital part of our anesthesia curriculum. 6 months of non-stop academic activity involving various topics from various speakers all over from India, which is a very, very impossible task possible by our academic chairman A.L. sir. I thank our A.L. sir for this very magnanimous and very important, difficult task underwent very easily. Another 6 months of academic activities awaiting. I request every member and every practicing anesthesiologist, postgraduates to utilize this Pudukkottai Budan every Wednesday and gain knowledge which will be useful for your practice and for your examinations. I hand over the proceedings to Dr. A.L. sir to conduct the webinar. Thank you. Over to Dr. A.L.
Thank you, Dr. Suresh Kumar, President. I extend my greetings on this Ganesh Chaturthi day, and I pray let Lord Ganesha showers all his blessings on all of us so that we will not have any airway problems when dealing with the patients. And today is a very good day because first time the youngest faculty, Dr. Ratnam, is from Pudukkottai. She is from Pudukkottai, and surprisingly, her husband is also an anesthetist. He is Dr. Karupaya. He is a cardiac anesthetist, and it is very difficult to see a pair of anesthesia, and now they are mutually anesthetizing each other, it seems. So it's a good thing to see, and a person from Pudukkottai is speaking from Maharashtra now through the webinar, and she is doing her 3rd year residency in Krishna Institute of Medical Sciences, Karad, and her father-in-law is a topmost physician in Pudukkottai, Dr. K. Ramanathan. So she's a host from ISA Pudukkottai, and I have seen Dr. Ramanathan also entering the webinar, I think for the first time in these 24 weeks, just because his spouse is participating. So we welcome Dr. Karupaya also for this webinar. And she is interested in pain medicine, regional anesthesia, obstetric anesthesia, and hopefully we will be having a bright star in the anesthesia field in future. So I congratulate and welcome Dr. Ratnam for this webinar. And even though it is a Vinayak Chaturthi, I had so many messages, whether today that Pudukkottai Budan is there or not. So that creates an enthusiasm among the anesthesiologists in the whole country And people are asking me whether it is happening or not. And some people are asking, I have missed that last webinar, whether I can have a recording or not. So that way, Pudukkottai Buddhan is popular because of the topmost faculties in the country are participating. And the next lecture is going to be by Dr. Caroline Satya on airway assessment. And Madam did her MD from the prestigious Christian Medical College, Vellore. And she has worked as an assistant professor in Vellore Medical College, Christian Medical College, Vellore. And she has been a freelancer for some time. She was working in Hanna Hospital in Madurai. And now she is a consultant Apollo First Med Hospital, Madurai. And she has a very passionate thing towards airway. And she volunteered to talk about airway assessment. And Madam is very good in that airway management. And to match her airway assessment, if we have a difficult airway, how to tackle that? Then immediately Dr. Shraddha Nayak came to my mind. Dr. Shraddha Nayak is a professor in Krishna Institute of Medical Sciences, Karad. She's a topmost person in the Karad. She's the secretary, Karad City branch. And see, I have visited Karad twice. And Madam has organized the RainCon conference very well. She has organized so many CMEs. She has so many publications. She's a well-known speaker. The surprising fact is, as every year advances, her age decreases. That is the best part of Dr. Shraddha Madam. And she is always energetic and young. And whenever it comes to academic, her enthusiasm is at the highest. She used to coach her students also very well, and she has brought a real Ratnam jewel with her. And I thank Dr. Shraddha Nayak for her active involvement in the academic field. And to top that all, now we need to have a chairperson. And as it is a airway, we have a person dedicated himself for airway management by name Dr. Sudesh. Sudesh is a professor in Bangalore Medical College. He did his UG in Mandya and PG in Ballari. And see, he has so many national publications, more than 20. And he has 6 international publications also. And he is arranging an airway workshop also in Bangalore in near future. So he is a dedicated person. And the surprising fact about him is he's from Karnataka, but his parents lived in Palakkad and the ancestors lived in Coimbatore. So he covers Tamil Nadu, Kerala, and Karnataka. So I don't know who is having in Telugu. So he may be attached with Telangana and Andhra Pradesh also in future. And he's the best person to be a chairperson for this webinar. And I wish you all the very best. And I hand over the session to Dr. Sudesh. Sir, please take over.
Thanks a lot for your kind introduction, Meenakshi sir. Without wasting much of your time, I think we can go ahead with the presentations now. First, I would invite Dr. Ratna Pannipan or Ratnam PL to start with her proceedings on nasopharyngeal airway. Dr. Ratnam, you can proceed with the permission of the chair, Suresh Kumar sir and Parisami sir.
Yes, sir. Yes, sir. Thank you. You can start. Sir.
Yeah, thank you, sir. Thank you.
Yes, sir. Ellen sir for that amazing introduction, and good evening everyone. Myself Dr. Ratnam PL, doing final year anesthesia in Krishna Institute of Medical Sciences, Karad. I'm honored to be a part of this academic program, and I thank ISA Pudukkottai for the opportunity. Moving on to my topic, today I'm going to talk about nasopharyngeal airway. I'll be covering the following aspects: what is an airway, uses, indications, contraindications, types, sizes, insertion technique, complications, ongoing management, monitoring, and documentation. What is a nasopharyngeal airway? Also, it is also called nasal trumpet. It's a short, flexible, uncuffed tube which is inserted nasally along the floor of nasopharynx past the base of tongue to maintain a patent airway. Once inserted, the nasopharyngeal airway prevents the patient's tongue from occluding the airway. It curves to fit the curvature of the nasopharynx. It is available in different length and internal diameters. It is made of sterile, made of plastic, either polyurethane or latex rubber or latex free medical grade polyvinyl chloride. It is made of non-toxic material free from lead, which strictly meet FDA requirements. Nasopharyngeal airways have a soft beveled tip that minimizes a tissue trauma during insertion. The other end is flared to prevent the complete retraction of the tube into the nasal cavity. Uses of nasopharyngeal airway. It is also used as an alternate device to maintain the airway through the nose. It offers an access for nasal with minimal discomfort. It is used where the conditions has limited mouth opening or pathology of oral cavities where it is difficult to insert oral airway. It is also used in conditions like pharyngeal surgeries, fiber optic bronchoscopy to apply CPAP. It is better tolerated than oropharyngeal airway in semi-conscious patients and also in awake patients. Why nasopharyngeal airway over oropharyngeal airway? Nasopharyngeal airway is better tolerated and it can be fitted with a tracheal tube connector and used as an anesthesia breathing circuit. If an oropharyngeal airway is placed in a patient's lighter plane of anesthesia, it can stimulate the gag reflex and which increases the risk of vomiting, aspiration, and laryngospasm. Indications to maintain the airway patency. Conditions where it is difficult to insert oral airway, semi-conscious patients not tolerating oral airway, conditions when there is a risk of obstruction, example seizures, macroglossia and micrognathia, facilitate suctioning in patients with a weak cough or neurocognitive impairment, in conditions like craniofacial abnormalities, example Peary-Robbins syndrome. It is also used to dilate the nasal passages in preparation for nasotracheal intubation. Contraindications. In traumatic brain injuries and central facial fractures, there will be tear in brain dura. So it may lead to CSF rhinorrhea. Nasopharyngeal airway placement in these kind of conditions may infect the sterile CSF, which may lead to meningitis. Nasopharyngeal airway placement in basilar skull fracture or cribriform fractures could penetrate the anterior cranial fossa because cribriform bone is a thin bone which connects the posterior roof of the mouth to the ethmoid sinus, affects the anterior cranial fossa. It is also contraindicated in anticoagulant therapy, coagulopathic disorders, transsphenoidal surgery, choanal atresia, or other nasal obstruction, active sinonasal infection, and recent postoperative rhinoplasty or septoplasty. Different types of nasopharyngeal airway. It is made of rubber and has a large flange at the nasal end with a bevel at the pharyngeal end. Binasal of two nasal airways joined together by a connection that has a 15 mm adapter for attachment to the breathing system. The distal tips are near the larynx just below the tip of epiglottis. Epistaxis airway, it is inserted into the nose and inflated. It is useful in epistaxis by providing local pressure and it is available in several sizes. Linder nasopharyngeal airway, it is a clear plastic airway with a large flange. The distal end is flat and not beveled. It is supplied with an introducer which has a balloon that can be inflated and deflated by attaching a lower syringe to the one-way valve at the other end of the introducer. Rush airway, it is made of red rubber. It has an adjustable flange at the nasal end. The pharyngeal end has a short bubble. Components of nasopharyngeal airway, it has a round curved body, bevel, and the proximal end has a flange. Safety pin is provided to prevent the airway from migrating into the nasal cavity. On insertion, it should be passed backwards through the nasopharynx such that its distal end lies beyond the pharyngeal border of the soft palate, but it should not go beyond the epiglottis. Sizes of nasopharyngeal airway. Sizes of suitable Portex nasopharyngeal airway. For short female, it is 6, pin 1 cm from flange. For average female and short male, it is 6. For tall male and tall female and average male, it is 7. For tall male, it is 8. Based upon average height, females being 163 cm and males 178 cm, according to Stoneham and Roberts et al., which may vary in our Indian population. Different sizes of nasopharyngeal airway in pediatric population. When we use a suction catheter, use a suction catheter that is no more than double the internal diameter of the nasopharyngeal. For example, if we use a size of 5 mm of nasopharyngeal airway, we should use no longer than 10 French catheter. Suction catheter no larger than 10 French catheter. Choosing the right size. To determine the correct size, we should measure from the tip of the nose to the tip of the earlobe. In addition, choose a nasopharyngeal airway which has a diameter a little smaller than the patient's nares. And evidences that there is a strong relationship between a nasopharyngeal airway length and the subject height. Insertion technique. Place the patient's head in the supine position and choose the appropriate. Apply the lubricant. Bevel should nasal septum and insert perpendicularly in line along with which follow natural curvature the nasopharyngeal cavity until the flange rests against the nostril and confirm the airway patency. Here is the video showing the insertion technique. This is for the right nares.
Patient's right.
When we insert on the left nares, once the nasopharyngeal airway reaches the nasopharynx, we should rotate it to 180 degree and then proceed so that it resumes the alignment of the natural curvature of the nasopharynx. Ideal nasopharyngeal airway should lie approximately 10 mm above the epiglottis. Complications. It can injure tissue. It can cause tissue trauma and bleeding. Migration into the nasopharynx of the entire nasopharyngeal airway. Portex nasopharyngeal airways have a flange and are supplied with a safety pin to prevent its migration into the nasopharynx. Intracranial insertion of the tube. Ulceration with long-term use. Latex allergy. Choosing inappropriate sizes will compromise its effectiveness. So when it is too large, it can cause obstruction. It fails to separate the soft palate from the pharynx. When it is too large, it aggravates the cough and gag reflexes, which can precipitate vomiting, aspiration, and laryngospasm. It may pass anterior to the epiglottis into the vallicula, where paradoxical airway obstruction can occur if the nasopharyngeal airway lumen is pressed against the soft tissues. It may go into esophagus, which leads to gastric distension. Ongoing management. Frequently check the nostril for blanching or redness. If blanching occurs, required. Patency of the nasopharyngeal airway can be checked by holding a metal teaspoon, and we should check for fogging on the surface of the teaspoon. If the nasopharyngeal airway is blocked, try using 0.9% NaCl drops, 0.5 ml, and perform a suctioning. The use of the nasopharyngeal airway should be reviewed regularly by a primary team. Monitoring and documentation. A patient with a nasopharyngeal airway should have a continuous pulse oximetry and be visually checked at least every 30 minutes. Document in the clinical notes the date of insertion, size, and the type of nasopharyngeal airway. Conclusion. As the patient's level of consciousness declines and cough and gag reflexes diminishes, an oral or nasal airway provide more therapeutic benefit until an advanced airway can be placed for further management. The nasopharyngeal airway is a simple piece of equipment. It is effective and has many advantages over oropharyngeal airway, but appears to be used less frequently. Thank you.
Okay, Dr. Ratna, it was an elaborate and very nicely presented topic. You concised all the things very nicely, right from the types of nasopharyngeal airway and the right selecting the right size and making a proper use of it.
Thank you, sir.
I think you can you elaborate on use of nasopharyngeal airways in other situations other than for maintenance of patency?
Dr. Sutish,
Yeah, I think yes, sir.
I
Yes, sir.
request
I
please
think I will
discussion will have at the end so that it will be a comprehensive one.
Correct, sir. Now I just missed it. Sorry, sir. Sorry. I think we can move to the next speaker, Dr. Caroline ma'am, for airway assessment topic.
Shall I share my screen, sir?
Yes, ma'am. Yes, ma'am. Please go ahead, ma'am.
Good evening, everybody, and a good evening to Pudukkottai Budan. I thank the office bearers of ISA Pudukkottai for giving me this opportunity to be in your midst and give a talk on airway assessment. I would like to extend my special thanks and appreciation to the academic chairman, Dr. A.L. Meenakshi sir, too. So moving on to the topic, it is airway assessment. Okay, as you all know, airway assessment done pre-operatively goes a long way in preventing airway-related mishaps. I'm sure everybody who have logged in will agree with this. So what is the role of airway assessment? The role of airway assessment is to identify potential problems with regard to the maintenance of oxygenation and ventilation during airway management. And then you formulate an appropriate airway plan and incorporate a staged approach. Why do you need a staged approach? The purpose is to manage a predicted difficult airway or the institution of emergency airway management. So why are we doing airway assessment? We are seeking to predict if we can manage what patients normally do for themselves. What do they do for themselves? They maintain the gas exchange, airway patency, protection of lower airway against aspiration of foreign material. Now, once the patient is unconscious and apneic, and this can be because of our anesthetic, they lose the ability to do the set parameters. So airway assessment has predicted difficulty. If the airway assessment in this situation has predicted difficulty in maintaining these vital functions, then the predictions should help the anesthesiologist's choice of intended primary and rescue approaches in managing patient's airway. See, we use a GPS wherever we go. When we go to a new place, we use the GPS and it instructs us to take the route which is easy to go, where there is less traffic, so that you reach your destination on time. Likewise, airway assessment helps you like a GPS. It helps you, it takes you in the stepwise pattern, and finally, it helps you to reach your goal, and that is intubation. So what is the aim of airway assessment? To ensure any abnormalities that are present and to determine if any extra preparations are needed during the implementation of the intended approach, and also screen for difficulty with pathways other than intended technique. This we have to do. For example, if tracheal intubation is the intended technique, we should screen for difficulty with bag mask ventilation and supraglottic airway device use and vice versa. So what is the importance of airway assessment? You can say it is just an inguinal hernia, I'll just do a spinal and get away with it. Or it's just an elective LSCS, I'll just do a spinal. Does it mean you don't have to do airway assessment? No. Airway assessment should be done for all anesthesia encounters, including regional anesthesia or monitored anesthesia care. Who knows? The spinal can be partial, it can be a patchy block, it might not work, and you might have to give a general anesthesia. So for all procedures, whether it is a planned regional or a monitored anesthesia care, you have to do the airway assessment. So in airway assessment, ask yourself questions and answer them. Is there information about previous airway difficulty, any previous anesthesia record available? Will I be able to mask ventilate this patient? Will I be able to insert a supraglottic airway? Will I be able to intubate this patient? Will I have to do an awake intubation on this patient? Is there a risk of aspiration because pregnancy, chronic diabetic, morbid obese patients? Front of neck access, will it be easy? Can I extubate this patient safely? So don't forget the patient history. It can give light on certain aspects, and examining old anesthesia records is very important. See, it's just like you go shopping in Reliance showroom in Madurai. The computer lists all your past purchases from Reliance at Chennai or any other place. Likewise, the anesthesiologist who manages the airway should have access to records detailing earlier episodes of airway management in other hospitals too. The important point I want to put forward here is your anesthesia documentation. So in case you have a difficult airway, in case you're doing a difficult airway, please document it in your anesthesia record so that it might be useful for the patient in a future. When the patient goes in for another surgery in a different hospital where some other anesthetist will be anesthetizing the patient. Inclusion criteria in airway assessment. Difficult airway alert. Check the previous anesthesia records for airway-related issues. History of gastric reflux, rheumatoid arthritis, ankylosing spondylitis, diabetes mellitus, presence of OSA, increase in BMI, physical examination for congenital anomaly, which can alter airway, like Perimotum syndrome, Trichothyrotomy syndrome. You have to include the mouth opening, Malampatti, dental status, the Thyromental Distance, Jaw Protrusion Test, neck movement, fresh trauma like facial injury, mandible maxillary fracture, old trauma like chemical corrosive poison intake and burns. And what is the advantage of airway assessment? You can revisit. You can rethink also. See, ultimately, the results of airway assessment may suggest the need to revisit the originally planned technique. For example, if the airway assessment suggests if you are planning for a general anesthesia, but in the airway assessment, if it suggests difficulty, you could revisit whether a case originally planned under general anesthesia could feasibly and safely be performed with the regional anesthesia. So what is the outcome of airway assessment? See, in medicine, there is no point in performing a screening test unless you're prepared to act on its results. It's the same with airway assessment. It may indicate the need to move to an awake approach. You might have to change the originally planned technique, or you might have to take precautions, extra care during originally planned technique, like have different size blades for laryngoscope, smaller size endotracheal tubes, different types of bougies, etc. And also get a senior colleague standby in the operation room. Now, airway and diseases, because many of the diseases have airway problems, and we need to know what are the diseases which could pose a problem in airway, like rheumatoid arthritis, ankylosing spondylitis, diabetes mellitus. These diseases can have limited joint mobility. Rare syndromes like Perimotum, Klippel-Feil, Trichothyrotomy, Down syndrome, Turner syndrome, obesity and OSA. Trauma, when you have facial fractures, there can be soft tissue edema, chemical and thermal injury to the airway, mucosal edema, and infection, epiglottitis, abscesses like submandibular, retropharyngeal, Ludwig's angina. There can be a compromise in the airway. Tetanus, trismus, thereby mouth opening will be restricted. Upper airway tumors like in pharynx and larynx, lower airway tumors like of the trachea, bronchi, and mediastinum. Post-radiation therapy, which can alter the anatomy. It can disfigure. Scleroderma. Patient can have a tight skin, and there can be temporomandibular joint involvement. So airway assessment, how to go about it? See, this is how we'll go. History, physical examination, mouth opening, dentition, temporomandibular joint mobility, thyromental distance, cervical spine, other factors like pregnancy. So history is very important. So look at the history of any prior anesthesia, whether it was uneventful or eventful. If eventful, the course of events and outcome. And radiation history, whether there is any distortion of anatomy, scarring or deformity because of that. OSA, have they done a stop bang, G reflex, comorbidities, medications, allergy, reason acute respiratory tract infection, or smoking, because these patients can go in for laryngospasm or bronchospasm. Then coming on to the physical examination, simple examination of the patient from the front and side is very important. Look at the faces, massive obesity, anomalies, retrognathia, macrognathia, micrognathia, buck teeth, short neck, macroglossia, whether the patient is edentulous, whether the patient has a beard. All these can make your mask ventilation difficult. Prominent chest or big breast, short fat neck, whether the patient is pregnant, whether the patient is able to lie supine, whether the patient has stridor, kyphoscoliosis. So dentition. See if the patient has prominent upper incisors, the buck teeth, and if the patient has any dentures, whether it is fixed or removable, and loose teeth. Receding chin, rectognathia, micrognathia, nose, deviated nasal septum, CSF nisoria, rhinoria, nasal polyps, history of epistaxis. A nasal intubation has to be avoided in the presence of clotting factors, deficiency, CSF leakage, nasal polyps, history of epistaxis, basal skull fracture. And when you have to do a nasal intubation, it is wise to test the nasal patency. So you do in your airway assessment, you do the spatula test. You keep the spatula just beneath the nose like this and ask the patient to breathe forcefully through the nostril. So you observe the condensation area of each nasal fossa. So if this side nostril is obstructed or occluded, then that side the condensation area will be less. Then the mouth opening, the temporomandibular joint examination is very important. So two distinct components to this action, each contributing about 50% to the total. The first is the hinge-like movement of the condyle through the synovial cavity. This accounts for the first 20 millimeter or so of the mouth opening. So you have to test this. You place one finger in front of the tragus and place the other finger near the mastoid process and ask the patient to open the mouth. When you do this, you will feel the indentation there when the patient opens the mouth. And you will also feel with your other finger, which is placed near the mastoid process, the gliding motion of the condyle. Now, the second movement of the temporomandibular joint is the forward displacement of the disc and condyle, accounting for another additional 25 millimeter or so of mouth opening. So this is the inter-incisor gap. Now, the normal mouth opening, adult mouth opening is 3 finger breadths. It's 35 to 55 millimeter. So you ask the patient to insert 3 of his or her fingers held vertically like this into the oral cavity in the midline. If the patient is able to do this, then the mouth opening is 40 to 60 millimeter. That is 3 finger breadths. If the patient is able to insert only 2 fingers or less, then it is considered as a major limitation and it is a non-reassuring sign. Now you have to test for the subluxation of the mandible. You do the mandible protrusion test or the jaw protrusion test as it's called. Open the mouth fully and the patient has to open the mouth fully and place their lower incisors as far forward relative to the upper incisors as possible. So you're checking the degree of subluxation, which is the maximal forward protrusion of the lower incisors beyond the upper incisors. So this is the mandibular protrusion test. You have 3 classes, class A, B, and C. In class A, the lower incisors can be protruded anterior to the upper incisors. In class B, the lower incisors can be brought edge to edge with the upper incisors. In class C, the lower incisors cannot be brought edge to edge with the upper incisors. You can also do the upper lip bite test, which is another similar to the mandibular protrusion test, and it's a bedside test. So here, this is the vermilion border of the upper lip. And in class A, the lower incisors can bite above the upper lip till the vermilion border. But in class 2, the lower incisors can just bite the upper lip. And in class 3, they're unable to bite the upper lip. And mouth opening and muscle spasm. So you have to differentiate between limited mouth opening due to muscle spasm and the restriction which is due to joint disease. For example, in mandibular fracture, there is trismus, lockjaw, inability to open the jaw due to the muscle spasm. But this is functional. This improves with general anesthesia and muscle relaxant. Whereas in a joint disease like rheumatoid arthritis, ankylosing spondylitis, the restriction of the mouth opening does not improve with GA and muscle relaxant. Now coming on to the teeth. Buck teeth can impair the line of sight. Loose teeth can be dislodged during laryngoscopy. So dental injury is usually caused by excessive pressure on the teeth by the laryngoscope. So you must be careful about loose teeth, dental caps and fillings and dentures. So dentures, you keep them on during your mask ventilation and take it off during direct laryngoscopy. And you have important point, you have to assess the number of loose teeth before laryngoscopy and check if they are present after your laryngoscopy. And this has to be documented. And during your airway assessment, if you find loose teeth, you tell the patient that there is a remote chance that the teeth can come off during anesthesia. So that, I mean, they know even if one tooth has come off, I mean, you can tell them. So this is the buck teeth. We have problem in the line of vision. Edentulous will have problem during mask ventilation. And when they are partially edentulous like this, it's difficulty. There is difficulty during laryngoscopy because your blade just hitches in between the teeth and it's a problem. So in children, do not forget to ask about loose deciduous teeth. And in old and edentulous patients, the bag mask ventilation will be difficult because the contour of the face is altered, distorted, and air will keep leaking during the mask ventilation. So what you can do is you can keep a ball of gauze into each cheek during the bag mask ventilation like this. In both the cheek, you can keep like this and then place the airway in between. So this will make your mask ventilation easy. Next, the tongue. The base of the tongue lies close to the glottic inlet. You have to assess the mobility of the tongue. What your laryngoscope does is it displaces the tongue into the mandibular space. So a large tongue or a small submandibular space prevent the displacement of the tongue, making the laryngoscopy difficult with poor glottic view. The relative size of the tongue in relation to the mandibular space is determined by the Mallampati scoring. So Mallampati classification was first described in 1985 by Mallampati, and then it was modified by Sampson and Young in 1987. We now use the modified form only, okay? So the method of performing is the patient should be sitting upright, the examiner standing in front. The mouth should be maximally opened and tongue protruded without phonation. So Mallampati was described by Dr. Sheshagiri Rao Mallampati, and we can be proud that he was an Indian-born American anesthesiologist. And these are the structures you look for. This is the uvula, and then you have the anterior and the posterior pillars, and this is the fauces. So fauces, and this is the hard palate. So the modified Mallampati classification, in class 1, you can see the uvula, the full uvula, you see the fauces here, and the anterior and the posterior pillars are visible. Soft palate, hard palate. In class 2, the uvula is only partially visible and the fauces is visible, but the anterior and posterior pillars are not visible. Soft palate, hard palate. In class 3, only the base of the uvula is visible and the soft palate and hard palate. In class 4, we can see here, very well see here, only the hard palate is visible. So Cormack and Lehane defined the laryngoscopy in terms of the best view of the glottis during conventional laryngoscopy. And Entis and Lee added a modified version that subdivided grade 2 into 2A and 2B, modified Cormack and Lehane classification. And Cook subdivided the grade 3 depending upon whether the epiglottis can be elevated from the posterior pharyngeal wall using a bougie or a introducer. This is Cook's modification. So this is Cormack and Lehane's classification. Grade 1 is you can see the entire glottis. In grade 2, you can see only the partial. It's only a partial view of the glottis. And the modified Cormack-Lehane classification is grade 2 is divided into 2 and 2A. Part of the cords are visible in 2, and 2A is only the arytenoids, so very posterior part of the cords will be visible. And grade 3 is only the epiglottis is visible, is seen. So Cook's modification is 3 and 3A. In 3, epiglottis can be elevated from the posterior pharyngeal wall. In 3A, epiglottis cannot be elevated from the posterior pharyngeal wall. Grade 4 is neither the glottis nor the epiglottis is seen. And then you have to look for the 3 distances. The first one is the hyomental distance. This is from the hyoid bone to the mentum. Grade 1 is more than 6 centimeter. Grade 2 is 4 to 6 centimeter. Grade 3 is less than 4 centimeter. If it is less than 4 centimeter, you have impossible laryngoscopy and intubation. Next is the Thyromental distance. So this is the Patency test from the upper border of the thyroid till the mentum. If it is 6.5 centimeter, it is normal. The patient's head is extended and the mouth is closed. So if it is 6.5 centimeter, it is normal. 6 to 6.5 centimeter, little difficulty you can anticipate. If it is less than 6 centimeter or less than 3 finger breadth, it is a difficult intubation. Then sternomental distance, the SAVA test. Here too, you keep the patient's head extended and the mouth is closed from the upper border of the sternum till the mentum. Less than 12.5 centimeter, you can anticipate a difficult laryngoscopy and intubation. And something more about the thyromental distance. This distance is to assess the mandibular space, which is anterior to the larynx. And this reflects the ease by which the tongue may be displaced by the standard laryngoscopy plane. So if the thyromental distance is short, that is, if it is less than 6 centimeter or less than 3 finger breadths, the laryngeal axis makes a more acute angle with the pharyngeal axis. You all know that for laryngoscopy, we need all the 3 axes, laryngeal, pharyngeal, and the oral axis to be in alignment. So here, when the thyromental distance is less than 6 centimeter, the laryngeal axis does not get aligned with the pharyngeal axis and it will be difficult laryngoscopy. So you have the thyromental height. This is a new airway predictor proposed by Epistaxis et al. Shorter thyromental height is associated with difficult laryngoscopy. So this is the measure of a vertical height from the anterior border of the thyroid cartilage and up to the anterior border of the mentum. So a cutoff of 50 millimeter allows optimum sensitivity and specificity when using this test. So when a shorter, I said cutoff is 50 millimeter. So when a shorter thyromental height is assessed, especially in patients with anterior larynx, you perform the burp maneuver, which improves the laryngoscopic view. The mnemonic is burp, that means backward, upward, and rightward pressure. The burp maneuver consists of displacement of the larynx in 3 specific directions. So posteriorly, you push against the cervical vertebra, that is backward pressure, and then as far superior as possible, that is upward pressure, and slightly lateral to the right, that is rightward pressure. In a Japanese study, both the cricoid pressure and the burp maneuver significantly improve laryngoscopic visualization, but burp maneuver being more effective. They found out that the burp maneuver was more effective. So what do you do in laryngoscopy? Actually, the blade pushes the tongue towards the left, and the visual pathway produced by this maneuver is to the right side of the oral cavity. You get a view in the right side. The rightward pressure in burp improves the visualization of glottis by moving the larynx more into the line of vision. Now, assessment for difficult intubation, you evaluate the 3-3-2 rule. The first 3 is the mouth opening inter-incisor distance, that is 3 finger breadth, and next is the hyomental distance. This is in 3 finger breadth, and then the thyromental distance, 2 finger breadth. Now, the neck, coming to the neck. The neck extension normal angle is 35 degrees or more. And the neck flexion, how do you assess that? You ask the patient to touch the sternum with the chin. And the sniffing position, as you all know, is ideal for laryngoscopy and intubation. We need the cervical flexion and atlanto-occipital extension for mask ventilation and laryngoscopy as well. So this, when the neck extension flexion is restricted, there are certain conditions you have to look for. In these conditions, we can have a restricted neck mobility, like in cervical spine injury, ankylosing spondylitis, rheumatoid arthritis, limitation due to radiotherapy, and when the neck circumference is more than 42 centimeter, and in obese patients with short muscular thick neck. You have to assess the atlanto-occipital movement. So you ask the patient to sit straight, hold the head erect, facing directly to the front. Then you ask the patient to open his mouth widely. Then you ask him to extend the head maximally, and the examiner examines the angle which is traversed by the occlusal surface of the upper teeth. You see here the patient is straight, The patient's mouth is open and he is extending his neck here, and this is the angle which is traversed by the upper incisors. So you do a visual assessment or use a goniometer. Grade 1 is more than 35 degrees. Grade 2 is 22 to 34 degrees. Grade 3 is 12 to 21 degrees. And grade 4 is less than 12 degrees. So grade 3 and grade 4, you can anticipate difficult laryngoscopy. You can also do this Delicken's warning sign test, which is a bedside test. You place your left index finger on the chin of the patient and your right index finger on the base of the occipital tuberosity of the patient. And then you ask the patient to extend his head. Okay, now you see the level of your left index finger and right index finger. If the left index finger goes above and it is at a higher level than your right, then it is normal. If the left and right are in line, then it might be a difficult intubation. And if the left is lower than right, then it is you can anticipate an extremely difficult airway. Coming on to the voice, check for hoarseness, change in voice, stridor. When there is a stridor, it is a classical sign of upper airway obstruction. And stridor at rest means airway diameter is reduced by about 50%. And then you have to assess whether the stridor is during inspiration or expiration. If it is during inspiration, it is supraglottic lesion. If it is during expiration or biphasic, then it is subglottic. This is the Wilson score. There are some parameters, some 5 parameters, and you have to do the scoring. So weight, so you give a score of up to 2, head and neck movement, receding mandible, jaw movement, and buck teeth. Then finally, you add all the numbers, your score. And if the score is equal to or 4, it predicts a difficult intubation. And radiological assessment is important, but there is lots to it. So due to lack of time, I have not gone into it. But when you anticipate difficult airway, you can do lateral, cervical, spine, X-rays, and you can do CT, ultrasound, and all that. Please read it up. And diabetes and airway is very important. Assess your diabetic patients with care. They can keep your adrenaline rushing. Don't take them light, okay? So to diagnose, just do the prayer sign and the tabletop sign. So prayer sign is inability to oppose the palmar surfaces of hands and fingers with the wrist dorsiflex. Ask the patient to do that. See in this picture that the patient is not able to do. And tabletop sign, inability, ask the patient to put his palm flat on the tabletop. So if the patient is not able to, if there is inability to make contact of the entire surface of the palm and fingers on the flat surface, then that is a positive sign. So all these can be due to glycosylation of tissue proteins, chronic hyperglycemia. And when you see these signs, you can anticipate a difficult airway. And diabetic autonomic neuropathy, they will make you sweat. They can have, these patients can have cardiac arrest on table. So you have to assess these patients really well. Then you have the palm print sign. So patients' fingers and palms are painted with blue ink and pressed firmly against a white paper. So grade 1 is all the phalanges are visible. Grade 2 is deficient interphalangeal areas of the 4th and or the 5th digit. Grade 3 is deficient interphalangeal areas of the 2nd up to the 5th digit. Grade 4 is only the tips are seen. So you have an intubation difficulty scale. 7 parameters are the N1 to N7 and you score. So N1 is number of attempts, 1 point for each additional attempt. N2 is number of operators, 1 point for each additional operator. N3 is number of alternative techniques, 1 point for each additional technique, like repositioning the patient, you give 1 point more. Change of materials like blades, ETT, stylet, you give another point. Change in approach from oral to nasotracheal, give another point. Change in technique also will take another point. N4 is Cormack and Legan grading. So grade 1 will be N4 0 and so on. N5 is the lifting force required. If it is normal, N5 is 0, or if you increase your lifting force, it is 1 grade. N6 is the laryngeal pressure. No laryngeal pressure, N6 is 0. If you apply laryngeal pressure, it is N6 is 1. N7 is the position of the vocal cords during laryngoscopy. If they are abducted, N7 is 0. Adducted, N7 is 1. Now you have the intubation difficulty scale here. Now you plot the score here. If it is 0, it is an easy intubation. If it is less than or equal to 5, slightly difficult. If it is more than 5, moderate or major difficulty can be anticipated. Now, coming on to the assessment of difficult extubation to close my talk. In 2012, the Difficult Airway Society published extubation guidelines. They highlighted extubation as a vitally important stage in patient management. So you need to have an extubation plan for both routine and difficult extubation scenarios. You need to plan whether you're going to extubate the patient deep or awake, whether you're going to use the Bailey maneuver, that is exchanging the endotracheal tube for a supraglottic airway device when the patient is deep. And you have to have your general preparation. Definitely you need to have a checklist. Keep ready a working suction, and in case there, you can anticipate a re-intubation, right? Everything has to be ready. You have to pre-plan. So you need to have additional set of endotracheal tube, laryngoscope, and your drugs. You need to see whether the patient is adequately reversed. And is the patient hemodynamically stable? Is the patient normothermic? Is the patient adequately pain-free? Have you given enough analgesia? Because you don't want to extubate the patient and the patient screaming with pain. So all this checklist you have to go through. So the behavior of the post-operative airway, you need to know. Trauma induced by attempts to secure it initially, because it was a difficult airway and there was some trauma inflicted during your initial intubation. And you have to see if there is a residual effect of general anesthetic agents, opiates, or inadequately reversed neuromuscular blocking drugs. And patients undergoing airway surgery, head and neck surgery, and those maintained in the Trendelenburg position or prone position for a long time, or with prolonged intubation, need utmost care and vigilance during extubation. And obese patients and pregnant patients, you have to give special consideration. And another one point in dental patients, when they have this maxillary and mandibular fixation, they do a wiring, stainless steel wires are used. So these patients usually go in for a nasal intubation, and during extubation, you have to be very careful, and you might have to sometimes, after extubation, you might have to re-intubate the patient in the post-operative ward also. Always, when you keep such patients in the post-operative ward, tell the post-operative ward staff to keep a wire cutter handy. You might have to cut the wires. Extubation is an art. Practice it. And I don't have anything to say about the selfie, but I definitely believe it is an art. We have to practice, and nothing like having a patient after extubation smiling and saying, "Thank you, doctor." Thank you. I'll stop sharing,
Carolyn.
sir. Yes, sir.
Yeah. Carolyn, ma'am, it was an excellent and exhaustive coverage of airway assessment parameters. You touched upon very nicely regarding the basics, and then went on to address the advanced methods of airway assessment, including ultrasound. Of course, paucity of time mentioned, but you had your slide was busy with a lot of information. I do feel that the postgraduates and the participants will definitely be benefited by those information. And it was very well covered, and a lot of practical tips were discussed in the presentation. So may I request the next speaker, Dr. Shraddha, Professor of KIMS Karat, to start with her presentation.
Thank you, sir. I'll now stop sharing.
Yeah.
Good evening, everyone. And I bring you greetings from ISA Karat City Branch and Krishna Institute of Medical Sciences.
Madam, can you share your screen?
Yes. Is that visible?
Yes, madam. You can proceed with the presentation.
Yep.
Yeah.
So today, after an elaborate discussion of airway assessment by Dr. Kathleen ma'am and a little input on nasopharyngeal airway by Ratna, I will now go to the next step of the airway management, like what will actually happen and what we actually have to do when we encounter with a difficult airway in a systematic manner. So the difficult airway algorithms. So let's have some definitions. Now, these definitions are according to the ASA, American Society of Anesthesiologists, about what is a difficult face mask ventilation. When we call it a difficult face mask ventilation, it is not possible to provide adequate ventilation as confirmed by the ETCO2 because of either an inadequate mask seal or excessive gas leak or excessive resistance to the ingress or egress of gases. Then is the difficult laryngoscopy, when it is not possible to visualize any portion of the vocal cords after multiple attempts at laryngoscopy. Then comes your difficult or failed tracheal intubation, which means a tracheal intubation which requires multiple attempts and fails even after that. Then failed or difficult tracheal extubation, which means the loss of airway patency and adequate ventilation after the removal of a tracheal tube or a supraglottic airway device from a patient with a known or suspected difficult airway. And a failed invasive airway or a difficult invasive airway is anatomic features or abnormality reducing or preventing the likelihood of successfully placing an airway into the trachea through the front of the neck. And there's something called inadequate ventilation, which is judged by a host of parameters like absent or inadequate exhaled carbon dioxide, absent or inadequate chest movements, breath sounds, auscultatory signs suggestive of severe obstructions, cyanosis, gastric air entry or dilatation of the stomach, decreasing or inadequate oxygen saturation, absent or inadequate exhaled gas flow as measured by spirometry or detected by lung ultrasound, and of course hemodynamic changes associated with hypoxemia or hypocarbia like hypertension, tachycardia or bradyarrhythmias. Then there is difficult supraglottic airway ventilation. It is not being possible to provide adequate ventilation because of one or more of the following problems, like there is difficulty in this SAD placement, or SAD placement is requiring multiple attempts, or there is inadequate supraglottic airway seal, or there is excessive gas leak, or there is excessive resistance to the ingress or egress of gas through the SAD. Now, these were the American Society guidelines for few terms that we commonly use when we encounter a difficult airway. But now, we all are following the Atmanirbhar Bharat Abhiyan. I am going to dedicate the next half of the lecture for difficult airway algorithms, which are published by the All India Difficult Airway Association. These are our own guidelines. These are our Indian guidelines. So I'm going to discuss the algorithm as per the AIDA or the All India Difficult Airway Association, because most of the PGs are nowadays asked specifically about the Indian guidelines. So the AIDA has published guidelines for difficult intubation in adults, in pediatrics, in obstetrics, in the intensive care unit, and difficult tracheal intubation during the COVID-19 pandemic. And then there is a algorithm for difficult extubation. I'll get through you all in like one by one through all of these. So once we understand the adult algorithm, the rest are almost more or less the same. So before we go to any airway, the actual handling of the airway comes to pre-oxygenation. So for pre-oxygenation, we need a 20-degree head up, a proper mask fit, and 3 to 4 minutes of tidal volume breathing. Or if we are in a hurry or if the case is urgent or emergent, we need to give at least 8 vital capacity breaths over 60 seconds, an oxygen flow rate of at least 10 liters per minute. A CPAP of 5 to 10 centimeters of water is recommended if that's possible and not contraindicated. Pressure support ventilation of 5 to 15 millimeters of H2O if that is possible. Apneic ventilation with nasal cannula at 15 liters per minute is what is recommended by the AIDA, and Thrive at 100% oxygen at 70 liters per minute. So coming to the guidelines, the AIDA guidelines for difficult tracheal intubation in adults goes through basically these 4 steps. Why I'm taking these steps before? Because once I show you the final algorithm, it's going to be very crowded and possibly not even properly visualized in this slide, and students will not be able to see what it means. It just looks complicated. So I'll get you through them in the stepwise fashion, and in the end, when you actually see the algorithm, you'll be able to read and understand and interpret it very easily. So there are 4 steps that every algorithm will go through. Step 1 is your laryngoscopy and tracheal intubation. If that doesn't happen, then comes a step 2, that we insert a supraglottic airway device to maintain the oxygenation. If that fails, we enter the step 3, which is the rescue face mask ventilation. And even that fails, we call it a complete ventilation failure, and we come to the last stage of the algorithm, which is the emergency trichothyrotomy. So all your algorithms, be it adult or pediatric or obstetric, are going to pass through these 4 important main stages. So we will discuss each step of these in a little more detail. So step 1 is laryngoscopy and tracheal intubation. So when you do a laryngoscopy and tracheal intubation, nasal oxygen via cannula at 15 liters per minute, this is apneic ventilation, should continue in the background. If your tube doesn't go in the first attempt, you can take maximum another 2 attempts, provided your saturation is maintained above 95%. Do not forget to mask ventilate between each attempt. Then when you change your attempt, try and change the technique, try and change the device, like shifting to a video laryngoscope or a McCoy blade or a longer blade or larger blade or whatever. Try and change the operator, because sometimes a couple of attempts and the intubator might be panicky, or he might be like out of his mind. Somebody else, a change of hand most of the time rescues the situation. So try changing the technique, the device, the airway operator, and use of proper adjuncts like a stillet or a bougie or likewise. And make sure that you maintain the depth of anesthesia during all these attempts. So that is your step 1 of laryngoscopy and tracheal intubation. If none of these work, in spite of the change of technique and bougies and stillets and changing hands, then we have to go to the step 2, which will tell you the role of supraglottic airway devices in difficult airway. So in step 2, we should preferably use the 2nd generation supraglottic airway device. Now, what is the 2nd generation supraglottic airway device? An airway device which have a gastric tube and which has a better seal are the supraglottic airway devices of 2nd generation. Then again, how many times will you try putting an SED? Again, you will have to give 2 attempts if only your saturation is maintained. If only your saturation is maintained above 95%. If it doesn't happen so, you have to either, and once you've put the supraglottic airway devices, you might ask, then what? Now I'm being able to ventilate through supraglottic airway device, but what we have to do next? So there are 3 options. Either you wake the patient up if you feel that the surgery is not safe enough to be completed on a SED, or you can continue your anesthesia with a supraglottic airway device itself if you think it is safe to do so, or if you have the enough expertise and equipments available, you can intubate the patient through the SED, but only using a fiber optic bronchoscope, no blind techniques here. So you can intubate through the SED provided you have the expertise to intubate through a FOB. If none of these work, then we have the next step. So before that, just have a look of what a 2nd generation SED means. 1st generation is one which only has an airway tube, but the 2nd generation has an additional design to reduce the risk of aspiration, like a double cup, like in ProSeal, or higher sealing pressures to enable the controlled ventilation at higher airway pressures, and an integral bite block and a gastric tube, which will prevent or protect better against aspiration. Then step 3, as we discussed, after insertion of SED or ventilation through SED phase, is the rescue face mask ventilation. So for rescue face mask ventilation, again, the nasal O2 through cannula should be continued in the background at 15 liters per minute. Ensure that the patient has adequate neuromuscular blockade at all times, so that your mask ventilation becomes optimum. And before you declare it as complete ventilation failure, a final attempt of mask ventilation with optimum techniques and correct adjuncts should be made. And if we are unfortunate enough that even this doesn't work, then we have to declare it as complete ventilation failure. The initial term of cannot intubate, cannot ventilate has now been replaced as complete ventilator failure by the AIDA. This is a situation where intubation and ventilation using a supraglottic airway device and a face mask all have failed, even after giving the best attempt. Even if the nooks here is, even if the oxygenation be maintained. So you don't have to wait for the saturation to fall or the patient to get hypoxemic to declare it as a CVF. You can very well declare it as a CVF once you're not able to intubate, or you're not able to ventilate through SAD or through a face mask as well, even if the oxygenation at this point of time is still maintained. Moreover, emergency cricothyroidotomy is now recommended while the oxygenation is maintained before the hypoxemia sets in. And the final attempt at mask ventilation should always be made, ensuring complete relaxation and a good optimal technique before declaring it as CVF. So, unfortunately, if we do land up in a CVF kind of a situation, all that helps us is an emergency cricothyroidotomy. Now, emergency cricothyroidotomy could be of three types. One is needle cricothyroidotomy. The other one will be a large bore cannula cricothyroidotomy, and a more definitive one, which is a surgical cricothyroidotomy. So needle cricothyroidotomy, essentially, we just have to introduce a 14 or 16 gauge IV gel cannula along with the stellate, and then remove the stellate inside and do jet ventilation through that and rescue the situation. But there are problems like barotrauma, breath stacking, aspiration, pneumothorax in this kind of cricothyroidotomy, and a definitive airway should follow very, very soon. A large bore cricothyroidotomy, where you mostly get those ready-made kits. These are less invasive than a surgical crico, and it avoids the need for jet ventilation. You can put a smaller tube and ventilate. And most of the times, the Seldinger techniques, cannula over a trocar kind of a technique is used for large bore cricothyroidotomy. A surgical crico, as the name suggests, is a surgical incision on the cricothyroid membrane and insertion of a ET or a tracheostomy tube through it. The classical technique followed here is stab, twist, bougie, tube. So you stab on the cricothyroid membrane and you twist it 90 degrees to make the incision larger, put a bougie, railroad a small size tube over it, and you can ventilate or even attach a circuit to it, and hence it is more definitive than a simple needle crico. So this is the summary of what we just studied. It's the same thing essentially. So step one of a difficult airway algorithm is laryngoscopy and tracheal intubation. So you have to keep giving apneic ventilation through nasal cannula. You can attempt a maximum twice if the saturation is more than 95%. You have to keep giving mask ventilations in between the attempts. Optimize the position, laryngeal manipulation, and the adjuncts used. You can change the operator and device if you think so, and ensure that the depth of anesthesia is maintained at all the time. Come to step two, if nothing of these works, we have to insert a second generation supraglottic airway device, try and maintain the oxygenation with minimum 2 attempts and mask ventilation between the attempts. If you're unable to ventilate through a SAD, we'll have to try a rescue face mask ventilation before we declare it as CVF and go for an emergency cricothyroidotomy. So now let's have a look at the actual algorithm. So this is how it looks. I'm sure this creates a lot of confusion. Let me tell you what I just discussed is this. The step one is laryngoscopy and tracheal intubation. Step two is insert an SAD to maintain oxygenation. Step three is rescue face mask ventilation. And step four is emergency cricothyroidotomy. And the very important thing that we have to note here, the big thing, is call for help. So the call for help, actually, maybe I've not mentioned it, but the call for help is the first thing that is to be done when you have the slightest doubt that this airway is going to be difficult, or you are probably going to land up in a situation which is a little more tricky than what you expected it to be. So call for help is the first thing, after which we'll have these 4 steps. And of course, there's a post-procedural plan of further airway, how you're going to manage the airway further. You have to treat the airway edema if it's there. You have to monitor for complications after you have secured the airway, after all this jugglery, and you have to counsel the patient and of course document it. So this is the adult algorithm for the adults in unanticipated difficult tracheal intubation. You're asking me about these arrows after the insertion of supraglottic airway device. This also we have discussed that once you are able to ventilate through the supraglottic airway device, you can either wake the patient up or continue the surgery on the airway device itself if you think it is safe, or you can intubate through the SAD using a FOB only. Tracheostomy remains your last option. So now we will have a look at the tracheal intubation algorithm in an obstetric patient. Essentially the same again. If you see these things, the steps, the points that you have mentioned are essentially the same. Only thing, when we give cricoid pressure in an obstetric patient, because she is at a high chance of aspiration, you are allowed to release the cricoid pressure during tracheal intubation if that is making your view difficult. That's the only extra point added in the first box. The second box is essentially the same. The third box is the same. The fourth box is also the same. Now, the point to be noted is, what will you do that if you are not able to intubate, but you are able to put a SAD in an obstetric patient? Now, what you want to do with the SAD since she is pregnant, since she is at risk of aspiration? So what they mention here is, you can continue the anesthesia through the SAD if it is very, very essential and it's in a very emergency situation, or you can intubate through the SAD via FOB only if the respirator is available, or you consider awakening the patient if the mother and child are stable. And the extra column that you have here after your crico is this. This is the Perimotum Cesarean delivery. So, like I discussed, if you're putting a SAD in an obstetric patient, you can continue if it's extremely essential, or intubate with an FOB, or awaken the mother simply if they both are stable. And Perimotum Cesarean delivery to be performed within 4 minutes. Within 4 minutes, if your patient was near arrest or arrest, to, as a last resort, to relieve her pressure on her large vessels, and possibly if it can give you a good outcome. So near arrest situation of the, or the lady arrest, the Perimotum Cesarean delivery within 4 minutes of the arrest is recommended. Coming to kids, difficult intubation in pediatric patient. Again, more or less the same algorithm, the same 4 steps of laryngoscopy. If that fails with the SAD, if that fails with the rescue mask ventilation, and last is your emergency surgical airway access. So if your child is less than 8 years of age and you have a surgical help available, you go for tracheostomy straight away. If the surgical help is not available and your child is less than 5, then a transtracheal needle puncture should suffice. Or if the child is from 5 to 8 years of age, needle cricothyroidotomy. If your child is more than 8 years of age, then needle cricothyrotomy and use pressure regulated jet ventilation and try to keep the upper airway patent. What about difficult intubation in intensive care unit? More or less the algorithm still remains the same. So what we have to concentrate is this part, which is pre-oxygenation in an ICU and induction. So the same box, I'm going to magnify for you in this slide. So it is recommended that 2 experienced people be together in ICU whenever there is an intubation call. NIV with 100% oxygen and a pressure support of 5 to 15 centimeters of water for 3 minutes is recommended before you intubate, if the situation allows you to do so. High flow nasal cannula O2 therapy or nasal flow, nasal oxygen flow at 15 liters per minute is recommended. Cricoid pressure can be given. Induction agents, you can use etomidate or ketamine with succinylcholine. Its choline is not contraindicated, of course. And IPPV with bag valve mask with a reservoir bag after you intubate or before you pre-oxygenate the patient. And you are given only a single attempt of intubation if your saturation is more than 95, if your mask ventilation is failing. So if your initial mask ventilation after induction fails, you can give only 1 attempt of intubation in an ICU patient. Otherwise, you have to move down to the step 2 of algorithm, which is your SAD insertion. So now, this is an algorithm of difficult extubation. Like ma'am in our earlier lecture very correctly said that extubation is an art, and it is nothing is more satisfying than see your patient getting extubated and smiling back at you and saying thank you doctor. So that's a very good situation, but sometimes luck doesn't favor you and you have situations of tricky extubations, difficult extubations. So yes, we have an algorithm for that also. So now this algorithm again looks a little complicated, difficult to interpret in the given slide. So I'll break it down for you as well. The first part is this, and the second part is this. So in the coming 2 slides, I'm going to show you this flow chart and this flow chart. So before that, could you see something like 4 Ds and 3 S's over here? Sorry, 3 S's, not 4 S's. So what are the 4 Ds of a probable difficult extubation? So if you had a difficult mask ventilation, if you have had a difficult intubation, or the patient required re-intubation for some reason, if you have a delayed recovery and there is difficulty because of any pre-existing disease like a mass or some anatomical deviation, etc. So these 4 Ds, you're likely to land up in a difficult extubation kind of a situation. And 3 S's are any surgical cause for airway compromise like a oral surgery or a maxillofacial surgery, any airway edema or suspected airway collapse. All this, and you know that you have to keep the difficult airway cart ready during extubation. So 4 Ds, if you have any of these 4 Ds, difficult mask ventilation, difficult intubation, delayed recovery, or any pre-existing disease, what will you do? This was the first part of the cycle. This is what we are going to see now. If your patient is fully awake and is obeying commands, you have to give O2 supplementation, lung recruitment maneuver if that is possible and not contraindicated. And if everything is good, you can extubate the patient over an air exchange catheter or under the fiber optic bronchoscopy guidance under vision. If you have these 3 S's of surgical compromise or a suspected airway collapse or airway edema, then what do you do? You have to consider doing a leak test. So you have to deflate the tube and see the cuff and see if there's a leak, and there could be a leak or there couldn't be a leak. So if a leak is present, you're in a better situation. You can do some lung recruitment and O2 supplementation, and patient is good and awake, you can extubate him over a air exchange catheter or over FOB under vision. If after removing the tube, the airway obstruction persists, then you have to re-intubate and even consider tracheostomy as per the situation. If your leak test is absent, it is better that you delay extubation. And if you're suspecting airway collapse, then attempt to extubate deep over inhalation anesthesia, or when your patient is breathing spontaneously over a AC or FOB. Mind you, this difficult airway cart has to be ready at all the given times when you are expecting any difficulty during extubation. So you can try, if the patient is spontaneously breathing, of extubating over AC, but if the obstruction persists, you come back to the same, you re-intubate and you go for a tracheostomy. Or sometimes you have to directly consider this option of tracheostomy if it's a long stand. So in cases like, let's say, long-standing large thyroid or something where you're suspecting a complete airway collapse. We are on the waning phase of COVID-19 pandemic. Most of us have lost the fear about it. But yes, we had a difficult time in the last 2 years. I just want to touch up very briefly over the difficult airway in COVID-19 pandemic algorithm as well. It is essentially the same algorithm that we saw first, that is the tracheal intubation in the adults, bearing a few things that we have to keep in mind, like the mask fit. The main problem of a COVID-19 patient, as we all know, is the aerosolization. So we are more exposed to the aerosols, and we have to primarily try and restrict the aerosolization as much as possible. So they have recommended an optimum mask fit with the 2-hand technique. So 2 operators holding mask nicely and tight with 2 hands, and somebody else ventilating for you. The most expert operator in the entire team of the OR in that particular time is expected to handle the COVID-19 airway. Consider the risk of aerosolization through SAD if you have put an SAD and trying to ventilate and conduct the case over it. Intubation through a supraglottic airway device in a COVID-19 patient is not recommended. And as in all other cases, surgical cricotherotomy, other than the needle and the other things, because they are recommending directly surgical cricotherotomy with neuromuscular blockade in a case of complete ventilation failure and Ideally, we are not supposed to try for needle trichothyrotomies and all those things and jet ventilation through it. We directly go for surgical crico if there is a CVF kind of a situation. So that's the only difference between only few key points, not difference, few key points that we have to bear in mind when we are handling a COVID-19 patient. Of course, the PPE should be done and dosed properly, meticulously, and level 3 PPE should be done all the time by all the personnel in the OR. The communication, the code languages, etc., and debriefing has to be done before the procedure begins beforehand in the donning area. The post-procedural plan, if you carefully see, all the algorithms have this particular box over here, all of them they have. So what is that post-procedural plan? Okay, you have come across an airway, it was difficult, you managed it at any one of these steps of 1, 2, 3, 4, somehow you have managed it, you have secured the airway of that patient, and everything is hunky-dory now, but what next? So after your procedure is done, after your airway has now been secured, after your case is done, there has to be some retrospection of and some future planning for patients like these. So you should have a further airway management plan for the patient ready. Secondly, you have to treat airway edema, if any, which is suspected during the course of your surgery or something. So if you had lot of attempts at intubation, or if you realize that the cords were already, the patient was already having airway edema when you tried to intubate for any reason, so that has to be treated. Monitor for complications. You might have tried with all your might to put the SAD, to put the tube, and you might have caused some trauma or something else to the patient. You might have jet ventilated through the needle crick, and then you have to monitor for the complications of what we have done in the cost of securing the airway for the patient. And of course, not to forget the counseling of the relatives and the patient and the proper documentation of everything that happened inside the OT right from the preoperative area. This is the list of things that the IDA has suggested should be there in the difficult airway card. The column on the left shows the mandatory things in your kit, and the column on the right shows the desirable things to have in an airway card, difficult airway card. So mandatory things include your working laryngoscope with Macintosh blades, face mask, ETTs of various size, Muggle forceps, Tillet, bougie, oral and nasal airways, ambu bag, then oxygen port, cannula or any catheter or other device to supplement high flow nasal oxygen during attempts at intubation, supraglottic airway devices, of course, nasogastric tube, airway exchange catheter, trichothyrotomy, wide bore cannula, and or if you have any other commercially available trichothyrotomy kit, if you have, then that should also be a mandatory part of your difficult airway card. The desirable elements include fancier things like McCoy laryngoscope blades, video laryngoscope, flexible fiber optic bronchoscope, entry exchange catheter, equipment for high flow nasal oxygen like Trife. And of course, the documentation. This form on the left, I'm sorry, I don't have a better resolution image than this on the entire Google net. So this is the difficult airway form given by IDA. And this is a documentation sheet after you encounter a difficult airway. So what it contains, it basically has the patient details in the first column, the name, the contact details, the doctor who encountered the difficult airway, and the contact details of the doctor who performed any airway maneuver on him. So that is the first part, this box. Then is the date of the event, details of the patient, the name of the patient, the date of the event that happened, and the contact details of the patient, and all those things. And then the third column is of whether there was any preoperative anticipation of the difficult airway, yes or no. And then all these questions are given as a list. You just have to say yes or no. Was there a difficult mask ventilation? Was the laryngoscopy difficult? Was it a difficult tracheal intubation? Was SAD insertion difficult? Were there complications at extubation? Was emergency trichothyrotomy required? And would you recommend awake intubation for this patient in the future? Also, a short details of how of the airway encounter that happened in the entire process, like how many attempts of intubation you gave, how it was the CL grade, what was the Mallampati score, and things like that should be documented for future purpose. So that's all. I wish you all a happy Ganesh Chaturthi, and may Bappa shower you all with choicest of his blessing. somehow as an anesthesiologist, I can't stop myself from seeing and observing that Bappa himself is kind of a difficult intubation. So that is it. I hope I'm able to give you a clearer concept of the complicated looking but actually easy algorithms. Thank you very much. Thank you very much for the opportunity, Meenakshi sir.
Shraddha ma'am, it was an excellent and exhaustive coverage of the guidelines. You made the guide easily followable by all the participants here. And in fact, it's very nice that you stressed upon the IDA guidelines, which was prepared in 2016. To add to it, there has been a lot of information collected based on that, and National Airway Conference, which is being held, which is scheduled of 2022. So we will be hosting the National Difficult Airway Conference in Bangalore. So with this background, I think I will open the for questions now. We can have some discussion regarding three topics. All the three speakers to be online now. Questions by some of the participants. To start with, we'll start with Dr.
Sutish, you have asked.
Sir, your voice is breaking.
Hello.
Dr. Sutish.
Yes, sir. Yes, sir.
You have asked something the initial period.
Yeah. Your voice is a little break. You are asking about the question which was asked in the beginning.
Sir, you asked this for the resident. After she finished her talk, you wanted to ask something. But our ALM sir told after all the three speakers.
Correct.
Just he was reminding you there. Yeah.
Okay, sir. That's what I got it, sir. I got it.
Yeah.
Meenakshi, sir, I got your point. You are asking. You wanted me to repeat the same question which I asked earlier. So that's the reason why I invited Dr. Ratna onto the stage now. Dr. Ratna, you had actually very well covered the entire topic of nasopharyngeal airways. Very nice coverage. You also talked about a lot of different types of varieties that is being available, including the double lumen type, which are not commonly used or commonly seen in many of the places. I really congratulate you for collecting all the details and covering all the topics very well.
Thank you, sir. Thank you.
Yeah, regarding this, Dr. Ratna, I just wanted to ask one thing. Like, is there any other way? I mean, other places where you can use nasopharyngeal airways when it comes to other than maintain a patency of airway? Is there any other place where you have come across its use? For example, in FOB or anything?
Yeah, sir. Fiber optic intubations and bronchoscopy. While doing bronchoscopy, we can use to do suctioning in semi-conscious patients.
Yes, correct. There are so many other there are so many other non. Or to say off the record uses.
Other than airway maintenance, sir, we can use in all these conditions.
Many times, if the airways like a tendency, if the nasopharyngeal airway has got, the nasopharyngeal mucosa is very congested, and there is a possibility of damage while inserting the FOB. So sometimes some of the anesthesiologists use nasopharyngeal airway as a conduit. They put the conduit, but before that they make a slit in the nasopharyngeal airway, so that they can place the nasopharyngeal airway and then pass FOB. And then once FOB is passed, they pull out the nasopharyngeal airway and open the split like this one book, and that you can remove the nasopharyngeal airway and then advance the tube over it.
So we use it as a dilator kind of a thing also.
Yeah, exactly.
Whenever you're giving a nasal intubation.
Nasal intubation.
So sometimes putting the tube through the nose is very traumatic. So to gauge the size of the tube, we put sequential airways, the smaller one first, then the bigger one, then the bigger one. So you get an idea whether the nares will take a 7.5 or a 7. And then these being softer, the airway is dilated nicely, the passage. And most of the times you've observed that the intubation per se is not traumatic. There's no bleeding, it goes smooth. That's another use that we routinely do.
Yeah. Yes, ma'am. So that's about nasopharyngeal airways. And then there are no questions in the chat box as of now with regards to nasopharyngeal airways. Now, may I ask Caroline Satya, ma'am, there are few questions which were presented, which were typed in the chat box during your presentation. Some of the participants were interested to know how to place that ball of gauze inside the buccal area of the patient's edentulous patients, and there was definitely a concern regarding the possibility of slipping of the ball and possibility of airway obstruction. I mean, iatrogenic airway obstruction. So I request you to kindly highlight upon this, madam.
See, when we usually place a throat pack, what we do is we leave the last bit of the gauze outside.
Yeah.
So same way, we can place a ball of gauze on both the cheek inside and leave the end outside.
Yes.
So
yes,
when you leave the end outside, there is no, it can't, you're always aware that the last bit is outside. And nowadays with the transparent mask, we can watch too.
Yes, ma'am. That would be a very good, that's a very useful and very basic practical tip what many people wouldn't have thought of, or sometimes it just goes out of mind sometimes. And nice that you brought up that point, madam. And the
Dr. Sudhish, can I ask one doubt? Dr.
Yes,
Caroline,
sir.
madam.
Yes,
to
sir,
Dr.
yes,
Caroline, madam. Madam, you said so much about airway assessment. Just I want to ask one question. If a 58-year-old man is posted for hernia or FE, will you do the same airway assessment for that patient as you described?
So, airway assessment for a anticipated difficult airway is slightly different. But for a normal patient, I think we need to see examining the patient. You look at the faces of the patient and all those things, your malampatti and neck extension, flexion, all that I think we need to do.
That's what, madam, I am asking you whether practically you are doing everything. Because even our postgraduates, they read so much, they write so much, but practically whether they are examining.
Yeah, we have a pre-anesthesia form in which we have to fill all this. So even now when I go to see the patient, I do all these malampatti, the neck flexion, extension, the thyromental, all these I do. So I think that is how we have to learn. As
chairpersons are in your institute, you are doing it as routine?
Yes, sir. I actually, as madam told, because it's a teaching institute, we ensure in the PAC clinic that whoever examines, at least in the PAC clinic, it is ensured that they do all the patients customarily and as a routine practice, so that in fact, they remember things better. In fact, even when they intubate also, when they put the scope and see the larynx, they are supposed to say which Cormack-Lehen grade the view belongs to before intubating. They are supposed to tell that and then intubate. So that is the practice what we are following. So nice. Yeah. So I think because
nice. Then it is a GCP. Then it is a GCP. Good clinical practice.
Thank you, sir. Thank you, sir. And and actually, if you see the slides of madam has put only those things which are practically important and which can be done day-to-day practice. She has not gone into the extensive anatomy part or physiology part, but she has really focused very well on what exactly has to be done in a preoperative checkup, and which can be easily done and doesn't require any high-end equipments or high-end monitors to assess the airway. I mean, that's the beauty of her presentation, ma'am. I really congratulate you on that aspect, madam. I think.
I'm not saying that it is not possible, but I want to know whether it is really practiced by the people.
Yes, sir. Yes, sir. No, as yes, sir. As you
whether
said,
it is really practiced, I'm asking. You're not doing that.
Yeah. Yes, sir. That is true, sir. But she has
that is the idea of this webinar.
Yes, sir. This at least
Madam was very clear.
Take home message that it has to be done. Exactly, sir. I do agree.
Yes, like Dr.
Thank you.
said, even in Christian Medical College, where I trained and where I was working just 2 years back, like sir said, all the PGs, when they intubate, they have to tell us the grade. Tell the senior what grade it is and then intubate. And we have a pre-anesthesia sheet which has to be filled earlier. And here, now where I'm working in Apollo also, we have
going on to the next question, madam. There was one question. I think this question can be combinedly answered by both Dr. Shraddha ma'am and as well as Dr. Kellen ma'am. Okay. How to go about difficult airway in cath lab, especially when the patient is inadequately sedated. So the question was whether can we use suxamethasonium as a muscle relaxant for intubation. So that's what the participant was asking. So I wish to take your opinion regarding this, madam.
About this is about using suxamethonium in
cath lab, especially when the patient is hemodynamically unstable.
In a cath lab, I think you have all the facilities and all, emergency drugs, everything you have in a cath lab. So if the patient is hemodynamically unstable and you have to intubate the patient, if there is no contraindication for the use of succinylcholine, I think you can go ahead.
I totally agree. Unless contraindicated, choline can definitely be used. And depending on how unstable the patient is, maybe we can think of using a little bit of intermediate also. If the patient is struggling too much, you think, and you feel it's very, inhuman to be intubating a struggling patient, or sometimes the view doesn't become optimal, you already panicked. The physician or cardiologist is also a little panicky, is asking you to intubate. So you can optimize the situation again based on the hemodynamics. But yes, choline can definitely be used unless it has some gross contraindication.
I agree with you, ma'am. Yeah, I think most of the people will have the same consensus in this regard, I think. But what I like to mention at this point is there is an entity called physiologically difficult airway, which is not often talked about. Especially this physiologically difficult airway comes into picture in the critical care unit or NORA settings, non-operating room or anesthesia settings, where there is limited manpower, limited access to the equipments and gadgets, and also you are in an unfamiliar situation. This physiological difficult airway is a situation where the airway is compromised due to not only the anatomical difficulty but also presence of deranged physiological parameters such as presence of hypoxia, hypercarbia, extreme degrees of acidosis, hemodynamic instability, especially bradycardia and hypotension. These are the conditions when they complicate the presence of difficult airway, that is known as physiologically difficult airway. Here, certain points are always told about. Whenever we attempt intubation, there is always recommendation regarding the use of vasopressors to stabilize the hemodynamic parameters, and also use of fluids. Especially now when it comes to cath labs, there is restriction on fluids, so therefore we might have to resort to use of vasopressors or inotropes there. In addition to that, as you all rightly said, we have to go for a smaller dose of induction agent or more cardiostable induction agent such as intermediate, and use of a generous use of a muscle relaxant. There should not be any there should not be any holding of amount of use of muscle relaxant. You should be generous enough to use the full intubating dose of muscle relaxant and proceed with the intubation. I totally agree with you, ma'am. Ma'am, the last question, what I noticed in the chat box was, some patients require smaller tube than that what is recommended for their age and size. Is there any particular reason for that? And if so, how to anticipate that is the question. I think here the question of assessment also is there, and also the practicality of how to go about. So I think both Caroline ma'am and Shraddha ma'am can add inputs into this.
See, if the patient is, for example, a Down syndrome patient, in those patients you can anticipate tracheal stenosis. They can have a tracheal stenosis. So you can keep ready smaller size tubes also. But in an adult, mostly unless the patient is having some edema. Now in your obstetric patients, you can anticipate edema. They have edema, soft tissue edema is there. So always we go in for a smaller size tube than we go for the normal patients. So I think it is, if you anticipate that this, the patient can have edema because of the maybe got facial trauma, soft tissue edema is there, we have to keep the small size tubes also ready.
Yes, ma'am. I think also in addition to that, there are certain indirect indicators, such as Madam told in your presentation, presence of stridor, presence of breathing respiratory difficulty, or a pre-operative diagnosis. For example, somebody comes with a huge thyroid, somebody comes with a mediastinal mass. It is imperative that there is a possibility of narrowing of tracheal diameter as well as laryngeal diameter, and that is where you are supposed to go ahead with this one. And the second part is when you are anesthetizing the patient, and many a times if the muscle relaxation is inadequate, or when you try to attempt at early, even without giving adequate time for the muscle relaxant to act, if you intervene and try to intubate, that is when you actually get narrow laryngeal opening, or you will convert a non difficult airway into difficult airway because of your technical fallacy. So I think that is also has to be kept in mind when you are managing. And as Madam Caroline ma'am and Shraddha madam aptly said, that whenever you anesthetize an airway, it's always imperative that you keep everything ready as far as difficult airway cart is concerned. Your laryngeal mask airways, your size of tubes, and different types of blades. That goes a long way in preventing an airway catastrophe, and you can still manage, you successfully manage even a difficult airway in that situation. I think that's quite a reason. Having said that, there is one thing, most of the Western books and most of the Western formulae which are given in our standard textbooks do take into account the Western population. However, the phenotypic, the geographic change in the phenotypes of anatomical phenotype of Afro-Asian people mandates that whatever size they say, we cannot use the same size. In fact, that way we have to reduce by one size than what is recommended as a standard. It's an unwritten rule most of the time that if somebody recommends a tube size of 8.5, maybe we'll have to go ahead with 8 or 7.5 in our situation because of the geophenotypic differences in the morphology of the person. So I think that may answer the question of that particular participant, I think. And there is one question, if I go through the chat box, there is one question saying, all these anatomical predictors may change when the patient is anesthetized, especially when there is loss of upper airway tone. So probably the participant is expecting us to say if there is a reason for that, and how do you proceed with that? Ma'am, can you just elaborate on that?
See, the airway assessment is before you anesthetize the patient.
Yes, ma'am.
Yeah. So all these predictors come into play before you anesthetize the patient, unless you have a patient who is rushed inside theater and emergency. Then, of course, you don't have time to do all your airway assessment. That is another different situation. But otherwise, you always assess the patient before you anesthetize the patient. So I don't get that question.
No, ma'am. See, they are probably assuming that once you anesthetize and when there is a loss of airway tone, there is a possibility that air, for example, a Malampati 2 becoming a Malampati 3, or probably a Cormac-Lehen. I mean, of course, we cannot talk about Cormac-Lehen, but Malampati is one thing what generally people think about. And that is where I think they are asking, I mean, is there a possibility?
What I feel is, sir, those predictors which are liable to change can also be predicted beforehand. Like, let's say a large thyroid mass. We are almost knowing that once you give a muscle relaxant, that mass is going to fall. And then maybe you do it without relaxation, or you change your plan to awake, or you keep something ready to lift the mass in case it falls back. So something like that might just happen, is predicted in this kind of cases most of the times. Or if, let's say, there's a pregnant patient, she has thrown a couple of fits in the morning and she's eclamptic and she's coming on the table, you expect her airway to have edema. Whatever mouth she opens, you know, where even if she's let's say Mandible 1 or 2, you still know that her cords are going to have edema. Her Cormac-Lehen grade might not be great. Even if it is seen, you might still have to pass a smaller size tube than what you would have done if that same lady was not pregnant. So most of these predictors can also be predicted with a careful history and a good observation. Like, same happened with the tube size. If you see the patient's nares, you know how much size tube to pass through that nares. You know 8 will break his turbinates. You can pass, let's say, 7.5 or 7. So in the same way, most of these predictors, if you have a careful history of the patient, or you observe the patient carefully for his faces and whatever mass or pre-existing disease or any abnormality that he's having, you possibly can get an idea of these predictors also, that, okay, I'm examining this patient, but after anesthesia, this mass might fall back. After anesthesia, there might be a collapse. Or after anesthesia, I might encounter a airway edema in this patient. So if you know the history of the patient, most of the times you can predict these changes also. That is what I feel.
Yes, ma'am. I completely agree with you. There are certain things. It's not necessary that we should focus only on anatomical predictors. We have to we have to focus on all the parameters. It's actually looking the patient from external, as you said, madam said rightly. We have to see from the front, from the side, and see all the factors which are coming in the way of our airway and which can probably pose a problem during the perioperative management. So if you look into all those things, then probably this question will not arise most of the 99% of the times, and you come across such a problem only in less than 1% of the times. Even if you see the NAP4 report, it is quite less when the airway assessment has been properly done. So there are two more things. There is one question for you, madam. Actually, does algorithm cover pediatric difficult airway? I think you have already elaborated very nicely in the. It does.
And I have put it in my slide also.
Yeah, exactly, madam. Exactly. And the question is also followed by how to assess pediatric difficult airway preoperatively. Pediatric
airway assessment. The rule is basically same. You look out for any syndromes. You look out for any mass that the child is having. Or maybe, let's say, a child with hydrocephalus. There are so many indicators which tell you, okay, maybe he will not allow you a Malampati. The child is very young. If he's adolescent, or let's say above 5 or 6, it can do, might as well that also.
Yes,
so detailed history and a careful observation. The lemon classification, like we used to say, you look,
exactly,
the Malampati, see for any obstructive features, see for the neck, the baby is short neck or there's some mass in the neck itself. Most of the time, neck mobility is not a problem unless the child has some disease pertaining to the spine. So, the rules more or less are the same.
Yes, ma'am. And one of the participants also says that neck extension and upper lip bite test are more predictable than bedside than MPT. I think that's already there are so many studies which have tried to compare the efficacy of various clinical assessment methods or tools, and they have found. This one upper lip bite test as one of the good predictors with more greater sensitivity and specificity, and also positive predictive value with regards to predicting the difficult airway. So I think you both Dr. Carolyn as well as Dr. Shraddha would agree with that point, I think.
Yes, sir.
And as Carolyn Madam rightly pointed out, the recent predictors such as height to thyromental distance ratio or the thyromental height, which is measured from the thyroid cartilage to the tip of the mentum, they are new predictors which have also thrown new light into the prediction of difficult airway, and they are also been found to have some amount of sensitivity and specificity with regards to predicting the difficult airway.
I could see one more question, sir, possibly for me only.
Yeah.
Somebody has asked how to perform this leak test, which I mentioned.
Yes, ma'am.
So the leak test on ventilator, like I mentioned in the algorithm. So what we have to do is to deflate. We have set some tidal volume on the ventilator, and it is delivering, let's say 400, 450 for whatever throughout the case. And now we deflate the cuff of the ETT and observe the expired tidal volume over the next few breaths. It will take time for the leak to set in. So over the next few breaths, you observe this thing and see if there is any loss of tidal volume there. And what is the difference? Like say, pehle 400, 450 deliver kara tha, now it is like 350, 320 variable. So you know that there is a leak of, let's say 80, 100 ml after you have deflated the cuff. So that is how the leak test is done. And we say that, yes, the leak test is positive or the leak is absent, or a little bit is like equivocal. 10, 15 ml, 20 ml, 25 ml. It's equivocal, as good as not. So you have to check the expiratory tidal volume on the ventilator after you deflate the cuff and check whether it has any leak as compared to the previous tidal volumes that were expiratory tidal volumes.
Well, ma'am, I think that's one of the important aspects. Most of us should focus upon the use of leak test quite often than not, because it's not only about a case of thyroid, but also there are so many situations nowadays with recent advances in surgical management and availability of laser, etc. Lot of intraoral surgeries and palatal surgeries, etc. are taking place. And if you remember our COVID pandemic, we were focused, we were coming across lot of and we have done around more than some 500 or 600 cases with extensive involvement of the palate, perforation palate, and involving the orbit, even intracranial extension, etc. So there was a lot of times when we used to see a lot of airway edema. So in such situations, I think, as you said, you perform the leak test, but most of the times in such situations, I think most of us go ahead with elective ventilation for at least 24 to 48 hours and allow the airway edema to settle before we plan for any extubation. So that is one to add up on above your commitment. Otherwise, I think as you before extubating, especially when you are planning, when you are extubating a patient with difficult intubation, because there is always a possibility of edema in the ensuing period following intubation, and there is always a possibility of airway obstruction which might occur if we don't predict that and if we don't do leak test. Well, ma'am, so it's all covered. I think there are no more questions in the chat box, and I don't see any participant asking, raising hand or anything. So in that case, I would like to congratulate all the three speakers on their excellent and very detailed deliberation of the topic. And it was a really very well covered lecture, madam. So I would now may I request Dr. Suresh sir to please take over from here, sir.
Yeah, sir. Thank you.
And I would like to thank
Dr. Suresh.
Yes,
I see Dr. Suresh. I congratulate you for the well conduct of the session with Dr. Shraddha Nayak, Dr. Caroline, and Dr. Ratnam. Actually, I was traveling for a marriage function from Tanjavur to Madurai. Exactly, I reached Madurai, the spot, and I thank you. You have given me a good academic feast while the traveling period. Now I hand over the session to Dr. Suresh, our president. Thank you.
Thank you, sir. Thank you. We have witnessed a very good and very good session, full of practical and very good academic activities. I thank our chairperson for his excellent navigation and discussions. They did their very best, and particularly they stick on to the time also. And all the slides and algorithms are excellent, and the updates are very, very nice. At this juncture, I just wanted to tell one point for the freelance anesthesiologists who are practicing solo, because they don't have the opportunity to work, the opportunity to have support in just like in institutions or any corporate setup. If they anticipate difficult airway in their pre-anesthetic evaluation, you should always have a help in your side. Knowingly better person will be very, very useful for saving the life of the patient when you face difficulty rather than an unknowledgeable person. So I thank everybody. Our treasurer, Dr. David, is waiting for official Thanksgiving. Over to Dr. David, please. Dr. David.
First of all, I would like to thank our academic chairman, Dr. Elam sir, for conducting a 24th successful webinar. And thank you, sir. I would like to thank today's chairperson, Dr. Sudhish, Professor, Bangalore Medical College and Research Institute, Bangalore, for sharing his wonderful experiences. Thank you very much, sir. And also thank today's speakers, Dr. Caroline Satya ma'am and Dr. Shradha Naik and Dr. Ratinam ma'am for making wonderful academic session. Thank you very much. And I also thank other faculties and the postgraduate for making successful event. I thank Kirola and A1 Logics for technical support. Thank you, sir. Thank you very much.
Thank you, all of you. I request A1 Logistics to close the session.
Thank you.
Thank you, sir. Thank you, sir.
Thank you. Thank you so much, sir. Thank you, everyone. Good night.
Thank you, sir. Thank you.
Thank you, sir. Thank you.
Thank you, sir.
Thank you. Thank you all.